community organizer. Williams works as a researcher and consultant on issues of equity within public health, public education, and local government policy. Currently, she's serving as a health equity planner at Lawrence Douglas County Mental Health Center. And Christina, who's also joining us, has a professional background in early childhood education with an emphasis in STEM-based early development curriculum. Presently, she holds a position as a community liaison to Lawrence Douglas County Public Health. She's a staunch advocate for Black women and women of color and works aggressively to bring awareness to the health issues affecting our underrepresented and minoritized identities surviving in Douglas County. Her equity lens focuses on eliminating the structures that make certain identities the consequences of the vehicle for vulnerability. Welcome, Alex and Christina, two very intelligent young ladies. I'm excited to have you with us.
Yes, thank you. Thank you. Thank you very much. That's a very lengthy bio.
But it was all necessary.
Absolutely. Right. So yes, we're very happy to be here. Very happy to speak to you on this issue. So if Alex, you have the slides ready, we can pull those up and get started.
I do. So first things first, BIWOC or BIPOC, I'm sure maybe a few of you have seen that term or that acronym floating around. Basically, it means Black and Indigenous women of color. For BIPOC, where this is a P, it's Black and Indigenous people of color. And so just a quick tidbit, this is the group that we were focused on and that we were working on. Obviously, we have a 45-minute parameter with which to give this presentation, and there are lots of different people of color underneath this umbrella. And so we had to prioritize and kind of figure out who we were going to talk about. I've given a lot of presentations about Indigenous women of color and reproductive justice within the Indian Health Service and early women's suffrage and how that interacted with Native women and culture. And so that's something that, as wonderful as that would have been to also present about today, we are going to focus quite a bit on Black and then also mixed Black and Indigenous. And so just a quick heads up about who we're focused on today. Let me share. Oh, there we go.
Thanks, Alex. So I'll jump in here and just read out loud to you what health inequities are according to the World Health Organization's 2017 definition. Health inequities are defined as differences in health status or in the distribution of health resources between different population groups, arising from social conditions in which people are born, grow, live, work, and age.
Alrighty, and then something that's really interesting about Black maternal and child health is that it does reveal intersections. And intersectionality is it's been around for a while, that term, but essentially it's about how different layers of our identity can intersect and create compound oppressions and unique experiences to those intersections of identity. And when we're talking about Black maternal health, we're talking about, the intersections of gender, poverty, and race. And a lot of maternal health work, just in general, already exists at the intersection of gender and poverty. There's a lot of research about access to care and early prenatal care, and as well as nutrition and stress reduction and those things among all women who are pregnant. And so, but the Black and Indigenous women of color add that extra layer of race. And so something that we were really looking into, and something that's a big part of my research, is looking at multidimensional and intersectional methods, as well as anti-racist methods and feminist methods. And that could be its own presentation in and of itself, but we just wanted to put those terms out there in case you wanted to do some additional research. All right. And then the United States has the highest maternal mortality rate among the affluent countries of the Western world. And something that gets misunderstood a lot in medical contexts is, we tend to blame Black women for having chronic health conditions in the first place, for having certain rates of obesity, for living stressful lifestyles. I've seen all kinds of things in the research, and it's very disempowering. It's very it divests from the actual framework of what's going on. It's white medical supremacy, and it's white supremacy permeating all factors of our life. And the fact that Black women have higher rates of chronic conditions is also endemic of white supremacy. And it's not that alone creates these health outcomes. It's these health outcomes that we're not focusing on to begin with because of racism. And so it's really, when it comes to maternal health and even Black child health, there's a lot of research about the particular health needs of Black infants and why they're more difficult to care for, particularly for white physicians who don't have a whole lot of Black patients. But when we think about the interconnectedness of everything, um, I have a quote on here from Berkeley about, Black women are more susceptible to maternal mortality because racial disparities and hypertension persist without remedy. And so what I really like about some of this research that we were looking at is it really put the onus of responsibility where it belongs, not on Black women for living in these conditions or for having these resources or lack of resources, but on the system that prevents them from accessing those. And then the last piece from this slide that I thought was really powerful was that women in general, so this isn't just for Black women, but for women in general, they typically have the extra burden of establishing their competence when advocating for their health, in addition to hopefully attaining better health outcomes. And so it is something to think about. All right. So these are a couple of articles that were coming out that we also looked at. We looked at a lot of science papers, but I thought some of the pop articles were really important because their titles were really catching. I'll kind of go back. So this one talks about how even when you control for socioeconomic status, that Black Americans are still experiencing poorer health outcomes. I thought that this one was really eye-catching. The quality of healthcare you receive depends on the color of your skin. Why America's Black mothers and babies are in a life or death crisis. And I think that this New York Times article talked about also the Serena Williams case. And Serena Williams's case was very powerful for a lot of Black women because she is super rich, super famous. She has probably some of the best health insurance you could probably get. I'm sure that every inch of her body is insured, and yet she still experienced what a lot of Black women experience in healthcare. I don't know if anybody's unfamiliar with what happened to Serena Williams, but she gave birth, and very shortly after, she was experiencing some health issues, and it was actually a health issue that she had experienced before. She's extremely body literate, and she was advocating for herself, but her doctors were denying her the specific care she was trying to get, and it almost killed her. And so that's definitely look into Serena Williams if you'd like to see a really high profile case of Black maternal health issues. And then America is failing as Black mothers. This Harvard Public Health paper was very, very good and included a lot of helpful statistics.
Yeah, speaking of stats and statistics and data, shown here is the infographic that was created by Alex Kimball Williams that was distributed at our Lawrence Douglas Public Health Department. Pre-COVID, you could receive care, you could be in our waiting room, and our patients that were receiving care were able to read this infographic while they're waiting to be serviced and waiting to receive care. Access to information is one of the things that we heard from our women participants in our focus group that they were lacking, and they wanted more. They wanted more information that was specific to their bodies, and they could tell them about themselves and their health outcomes. So this is access to information that we tried to provide all throughout our health department that specifically addresses Black women health data.
Thanks, Christina. And sorry, I actually took one of your slides that you were supposed to speak on. Sorry about that.
That's okay.
Um, so this is, we took a very deep look into a couple of things, including medical malpractice, the medicinal dose gap, the pain management gap. And as much as we'd love to take a very, very deep dive into each of these issues, we are going to kind of gloss over it because it does set up our research that we're going to spend the bulk of the presentation talking about. And we thought it was very important for you all to kind of see where we were forming our rationales and what data that we were kind of going off of. So the first topic being medical malpractice, I have a medical definition at the top there, followed by a more legal kind of definition, and then some examples of what constitutes medical malpractice. The medical definition is a legal cause of action that occurs when a medical or healthcare professional deviates from standards in his or her profession, thereby causing injury to a patient. And then the legal definition is it occurs when a hospital, doctor, or other healthcare professional, through a negligent act or omission, causes an injury to a patient. And then, so these examples of medical malpractice, I think a lot of Black women would relate to and feel that they've experienced. At least that was true for several presentations that I've given about this material, some to rooms exclusively of Black women. Of course, it's one thing to experience medical malpractice, and it's another thing to prove it in a court of law and to get your due diligence. But, examples include improper medication dosage, premature discharge from care. That was something that Serena Williams experienced as well, and a couple of other high profile Black maternal cases. Ignoring or misreading laboratory results, not taking appropriate patient medical history, failure to diagnose or misdiagnose, failure to order proper testing or recognize symptoms. Looks like poor or no follow-up or aftercare is a really big deal in maternal health because a lot of things can happen even up to a year after giving birth that can cause maternal mortality. A couple of trends that I thought was interesting in terms of clinical and other trial studies is that they disproportionately contain white participants, and they also disproportionately contain male participants, which is an issue for women's health across the board. In terms of clinical trial participants, only 5% tend to be Black, less than 1% tend to be Latino or Hispanic. And in terms of women represented, we're only 33%. And so that's pretty low numbers in terms of, the medications that we're developing, not really including our bodies. And the other trend that I noticed was that studies disproportionately focus on the needs of white people in the population. Many health issues are race specific in terms of their prevalence and incidence, diabetes being a really high ranking one. Only 2% of studies involve what they call minority health needs, which is unfortunate because minorities are more than 2% of the US population, and certainly more than 2% of the world's population. Something that's very interesting to me was that when it comes back to the genetic traits, so I have a background in neuroscience and medical research as well. And so I looked very deeply into this UC San Francisco research that their lab was producing. Only 5% of the genetic traits linked to asthma, for example, in white Americans applied to Black Americans at all. And so that means that we have medications that are linked to pathology and symptom alleviation for white bodies, but not for Black bodies. And it means that we're administering medication to Black people that may not even work on them and could have unintended side effects or consequences. Again, I wish I could get much deeper into that. But what's interesting to me that I noticed in all of this is that this is really a missed scientific opportunity, when we're only studying diseases and disorders and conditions and so forth in terms of how it affects white bodies, and also privileged regions such as the global north. We are missing the opportunity to fully understand a disease or condition. We're cutting ourselves off to only understanding one side of it. And this becomes detrimental when we think about precision medicine and infectious diseases like HIV/AIDS. I think a lot of folks are kind of familiar with the HIV/AIDS disparities, that we kind of only know a lot about certain strains that affect certain parts of the world and not those that affect other parts of the world, such as Africa. And if we put all of our resources to understanding all of HIV and all of AIDS, how much further along our research might be. And then I'm going to gloss over this part. Essentially, there is difference in liver metabolism across race. We're already familiar with how that works across age. We don't prescribe children the same amount of medicine that we prescribe adults. We're familiar with how this plays out in terms of weight. a patient's weight it comes into play when we're talking about how much medication that we're going to administer. We also know how it plays a role within sex. We don't give women and men typically the same dosages of things, particularly with mental health medications. But there's a lot of research about how differences also exist along the lines of race, and yet we don't include that at all. Like race does not play a part in how we administer medications, despite the research showing huge liver metabolism differences and also kidney differences in terms of kidney metabolism across race. And so this is a huge deal, in terms of like one-time medicines, but when you have long-term medicines or cumulative medicines, such as those that treat diabetes, some pregnancy complications, there's other ones, for mental health that are cumulative, you start to see issues, and you can see raised liver enzymes just on account of those medications being too high of a dose. And so in a nutshell, white folks have a very, very high liver metabolism. They metabolize alcohol and medicines and vitamins at, pretty stable, quick rates compared to other people of color. And so we're giving people of color basically too much medicine, depending. And then again, I'm going to gloss over this. Pain management has been a really trending research topic lately, especially as it relates to police brutality. We are more comfortable seeing Black people in pain and leaving them untreated and allowing them to experience pain and doing nothing about it in the medical sphere. And that is also very true in the public and law enforcement spheres. The medical professionals and medical students at the University of Virginia did an extensive study. And I love University of Virginia. I have them set up on notifications on ResearchGate. So every time they put out a paper, I'm notified because I have to read it. They do really good work there. But they found that medical professionals and students, so this is not the general population, they found that medical professionals and students believed that Black patients had fewer nerve endings, that they had thicker skin, that their blood coagulated faster or clotted faster, and that they had quicker recovery times post-trauma. And so just kind of letting that sit and just understanding, if that's what the medical people believe, imagine what the rest of us believe, and how this can play into Black maternal health. Because if we're discharging Black mothers quicker, if we're not scheduling them for as much follow-up care, if we're not believing their symptoms and allowing them basically to die, and same goes for Black infants, how it relates back to these pain management studies. They also believed that there's different studies that I was looking at that showed how much we under-medicate Black folks, particularly when it comes to pain medication. And these can be really serious when interventions and medications are chosen on the basis of patient pain, which is really true for Black maternal health. We are just depending on what people report about their pain. And also within cancer. So cancer is another big one where pain management differentials can have very real consequences. And then I say all of this to kind of talk about the point of Western medicine is to create good opportunities and health opportunities for all of us. It's to continue medical advancements and prolong our lifespan, increase our quality of life. And yet class, race, gender, sexual orientation, disability, and neurodivergence, neurodiverse, all of these things play a role in the level of care that we receive, as well as the medical advances available to us at both the research level that I talked about, as well as the clinician level in terms of patient-provider bias. So I'm going to hand it off to Christina. Thanks for bearing with me. I know that was some very difficult material to digest.
Yes, thank you. You just have such great knowledge. It's great to work with you and listen to you speak on this issue. But we are going to talk about the research questions. And the research questions we asked our women of color, we asked our Black participants. One of them were, what are the pre and postnatal experiences of Black women here in Douglas County? Now, we didn't ask that of them. We asked ourselves, and then we created a number of questions that ask, what are your health experiences, or what are your birth and pre and postnatal birthing experiences? So with the grant funded by KDHE, we focus on Black women's pre and postnatal birthing experiences. Because just like Alex said, she gave some information, but according to our 2018 Health Equity Report in Douglas County, Black babies are more likely to be born low birth weight, and Black women suffer a higher infant morbidity rate than the white counterparts. than their white counterparts. But with this grant, we were able to collect birth experiences shared by Black women living in Douglas County. I'm gonna gleam over it, but I'm gonna just kind of read from my notes here, but bear with me. But while using data collected by participatory research method during 2019 and 2020 from focus group participants, the participants were and are all self-identified Black mothers. They're all living in Douglas County with various educational and professional backgrounds. And all of the quotes and the words that we'll share with you here came from the Black women themselves that we interviewed, who currently, as of 2020, right now, live and have children under 5 years of age in Douglas County. So I gleamed over the research process, but here we have some examples. You can go on to the next slide, and next PowerPoint slide for me, Alex, please. Thanks. But
This one here?
That one right there.
Okay.
Yeah. So we're ready to go into the quotes. And I think it's important to hear Black women speak about their birthing experience. I think it's important to always listen to Black women. I think it's important that we understand that these are experiences that maybe others share who are also demographically, who are not Black, but as you will read, these are the quotes that came from the Black women who live in Douglas County. And what you read here is an example of provider care bias. Often the fact is that individuals and communities interacting with the healthcare system are subject to disparate treatment at the hands of clinicians. So I won't read this quote out to you. Hopefully you can read and kind of sit with that. But it was a focus group opportunity and participant who shared how she was feeling disconnected and she felt judgment from her provider. Next slide, please. All participants shared that their pregnancy was stressful, and prenatal stress can range from severe to moderate to mild, but we know that stress affects bodies, and studies show that mild, moderate, and severe stress can have negative influences on pregnancy outcomes and development for the infant. Next slide. This is a quote coming from a woman who noted there was a lack of resources available to them during pregnancy. She was proactive, she asked questions, and it kind of goes back into what we're talking about with Serena Williams, how there was advocacy that had to be done on the lack or on the behalf of the Black mother. Next quote, next slide, please. This quote speaks, and I'll give you some time. I'm sorry, I'm kind of walking us through this quickly, but this mother said that there was a lack of community and societal support, and she speaks to that. I think that's really a poignant thing to focus upon because there's a lack of support felt by our Black women in our community. But being without support and being pregnant is really a double edge, and it's something that we wanted to understand. And this is one of the quotes that speak to that. I think it's next slide. Here's another quote. Like I was pretty upfront, had lots of talks with my healthcare provider. I feel like there wasn't shared knowledge that was helpful for me. And this is another woman who's proactive and vocal, and she advocated on behalf of herself. And again, touching on Serena Williams, I'll go back to Serena Williams because she suffered blood clots, and had she not had advocated for herself in that pregnancy experience and in that room, she may have had a very different birthing outcome. Next slide. One of the women shared that you can be as happy as you want and try to have the explanative pregnancy glow, which I have never had because she was always stressed out and stress is an ongoing challenge for researchers. How do you measure stress in a woman? How does a woman express stress? But an ongoing challenge is understanding the role of racial and cultural stress in augmenting the effects of types of prenatal stress described in Black women. To collect those stressful accounts and to listen to the Black women who are experiencing stress and what that is and how that is and how that can be measured. But increasing data suggests that racial stress is a huge contributor to the persistently higher rates of low birth weight and infant mortality. Next slide. I think this is where you step in, Alex.
Yeah. So I'm just going to go over a little bit about the research and some of our findings. And I think overwhelmingly, we learned that our Black women in our focus groups felt very much unwelcome in medical and clinical spaces. They felt stereotyped in their doctor's offices. And that was unfortunate to hear about. It's something that, I think each of us, if you're a Black woman, have experienced, but it's one thing to experience it yourself, and it's another to hear everybody else in a room sharing that same experience. Another kind of commonality that we came upon was that appointments often felt really rushed. They felt that doctors and nurses weren't taking the time to fully answer their questions or understand their situation or meet their specific needs. A lot of them had expressed, feeling like they were just kind of in and out in terms of their appointments, and that they didn't get the chance to sit down and really understand what their doctors were telling them, and to get extra resources from even just the front desk folks as well. They felt that there wasn't enough information, and that they felt almost coerced into doing what was proposed by medical personnel, particularly around epidural and other treatments as well. And so that was disheartening to see, especially because, I've worked at a front desk at a clinic before. And I have noticed the differences in resource navigation and how we help some patients and we don't help other patients as much as we could, because we don't like their attitude, or, people don't like their appearance, or there's like so many things that come into play with what I would notice people helping some people and not helping others. And then, of course, a lot of them remember mistreatment. They were called mistreatment, particularly around their birth experiences, which is also disappointing. They reported that their pain was trivialized and that their situation wasn't appropriately focused on compared to the other patients present. And, that goes back to some of the pain management study that I was sharing about, and how, we see a Black person in pain and it just does not register the same as seeing a white person in pain. And that's something that needs to be addressed. And I think that we see a lot of like bias trainings and things like that going on. But it's not just what's happening in conversations, and it's not just what's happening, directly with the patient. There's a lot of internal work that needs to be happening, and bias work with the medical professionals. And, when we see statistics like the research that came out in August about white physicians, or Black infants rather, in white physicians' care die at a higher rate than when they're in a Black physician's care. Things like that are happening. And I don't think it comes down to how they're treating the parents necessarily. I think that's a part of it, but we need to also focus on just, all of the decisions that they're making, internal decisions and stereotyping that medical professionals are making that result in Black people dying. Some of the interventions that were elevated in the focus groups, as well as our research, was the idea of establishing a support group or support groups for Black women navigating the white medical complex and their appointments. Also, improvements to office protocols to ensure that the front desk staff are appropriately sharing resources with Black patients, particularly if Black patients are indicating that they're struggling or that they have questions. So improvements to office protocols would go a long way. That's the other end of bias training that I think gets overlooked. Bias training tends to just kind of focus on the medical professionals, but there's a whole slew of front of house people that Black patients interact with as well in these settings. And those people need to also undergo bias training as well. They definitely can impact the tone and the environment that Black patients are in. And there was also a call for an increase of accessible information about health practices and resources, information that the patients could understand, that they could take home with them, that was easy to access. Also, like we've been talking about, the idea of internal training for medical personnel and their staff. Black women felt that they wanted to self-advocate and, wanted assistance in self-advocating. They wanted to be included in spaces of influence around decision-making and how practices and policies are shaped. And then lastly, there was, potentially a need for programming centered on Black women's health experiences and pregnancy issues. I think a lot of the women will go into our focus group questions, but around the last question that we asked about what the women in the focus groups felt like contributed to low birth weight and other pregnancy complications, a lot of the women didn't know. And so there's this need to fill in a little bit of education, I think, to raise awareness and knowledge among Black women and also the non-Black community in terms of these Black pregnancy complications. But going backwards, let's see. A couple of things we want to elevate from our research process, we aren't going to get super detailed about it, was that there was a great deal of racial concordance. And that means that we had the same race facilitators, me and Christina, working with the same race focus group participants. And that increased the trust that was in the room and also the quality of the qualitative data that we collected. Patients didn't feel the need to tone police themselves or to explain the way that they were speaking or the terms that they were using, because me and Christina already kind of knew what they were talking about. And me and Christina worked on the transcription process as well for the focus group. So we listened to the recordings and we typed out everything that they were saying verbatim. And me and Christina, growing up, maybe using some of the same terminology and same language, we were able to understand what they were really talking about, what they were inferring to, and we were able to kind of fill in the gaps where maybe if you didn't have the same race facilitator or analyst, there would have been things missing, I think, in that transcription process. And then Christina mentioned it earlier, we talked about, we engaged in participatory action research methods, meaning that we involved the focus group participants and other legs of the journey. They were invited to meetings with us to help decide what we were going to do with this information. And they're also going to receive a full report ahead of its publication as well, so that they can approve of what we've written about. And then I think the last thing that we'll mention is that obviously COVID-19 affected our research process. We have a whole section of our report just talking about that and how we reallocated our funding and changed our plans, because we obviously couldn't do focus groups and, at the time when the pandemic was just starting, and we wouldn't think that that people really had time to contribute towards those focus groups at that time. Certainly now there's a lot of virtual events happening like the one that we're in right now. But for certainly earlier in COVID-19, we weren't going to continue the focus groups as they were being held. So that's all that I'll say about that. And obviously our goal was to improve the healthcare experiences for Black women and parents locally. Also to identify which resources help the Black parents the most. We had a focus group question just related around that. We wanted to empower Black voices, particularly within the public health domain, by reporting these results out. And if possible, if we could alleviate disparities. Now that's a huge thing that no one study or no one group is going to enact on their own. But if we can be a drop in that lake, then that's something really positive that we can be part of. And I think the kind of the through line that we were also working with is shifting the opinion that Black parents suffer as a matter of socioeconomic status and lack of access as the only reasons for that. We wanted to elevate the nuances, I think, of patient-provider bias. These are some of our focus group questions. I don't know if, Christina, you felt like talking about any of them?
Sure. I mean, the context, and I'll share a little bit of the background. These are focus group questions that we ran through a number of group that we were involved in with United Way, and we used Black women to look at these questions to ask what and how would you respond to these? I mean, there's a number of ways you can engage and ask, but we definitely did not want to come across polarizing, and we definitely did not want to come across as accusatory. And I think Alex has shared a little bit of that, wanting to know, why did you have a low birth baby, or why were you not able to access healthcare, or why did you not continue with your prenatal or your obstetrician, or your experience with the medical professionals, because that really would make a difference in how the room was open and warm and inviting enough to share. So these focus group questions came with a number of different lenses, but also was a work in progress. And I feel happy that we were able to come to the conclusion that we were with the questions here. And I won't read all of them, but I feel like Alex touched on the last one, number 6. What factors do you think contribute towards poor infant health, such as low birth weight or infant mortality? And that's one that's, it's that you have to understand and have a perspective about what low birth weight looks like, or what it is, or how it shows up in your life or in Black women as a whole. So that was the one that's a little touchy. We were kind of moving back and forth on that one because, again, we do not want to place the onus on Black women to understand, or to not to understand, or to share or feel as though they were responsible for the birth outcomes if they were negative.
Yeah, thank you for sharing that last part, Christina, because these focus group questions went through such an approval process and editorial process. And we wanted to create, a really good environment for people to share their truths. And I think a lot of times questions can be accusatory and they can be polarizing. And I think that this went through quite a process, and we could even continue refining the questions, of course. But yeah, I think that we created a really great room both times that we had focus groups, and that the participants felt that they could really share their truths. We had a couple of emotional moments as some of the women recalled their birth experiences. And so I just thought it was so powerful that we asked these really great questions, that we created a great space. We provided drinks and snacks. We helped provide transportation for anybody who needed it. There was on-site childcare so that people, would not experience barriers in that way as well. There was so much intentionality that went into these focus groups.
I do want to add to that. Oh, can you hear me? Okay. We reached out to a couple of mental health care providers so that we weren't traumatizing or creating an atmosphere that would be re-traumatizing a woman who was sharing an experience that was painful. But we weren't able to, and that's a side note, and I'll just share that to be transparent. We weren't able to connect with any mental health caregivers who could be present. But we did attempt. And if we were going forward, I believe we would probably put that at the forefront of what we do and how we engage. We would make sure that there was a mental health professional that could bring a patient or bring a participant back to some place.
Yeah, really great point. That was something that, going back, I would definitely revise, because yeah, these were very traumatic experiences for the bulk of the people there. And I think we kind of went in thinking, well, maybe 1 in 3 or 1 in 4 would have had a bad experience, but so many of them had really traumatic things to share. And so that was very surprising. And, yeah, definitely looking back, we would have some mental health support there for sure. Okay, so Christina had kind of mentioned that there was some local research that was happening through the Healthy Community Initiative at the Kansas Health Foundation over at the health department as well. And I'd love to give Christina a chance to kind of talk about, this is the work that happened before our focus groups that also helped inform our focus groups, and why we were focused on prejudice as one of the things that we wanted to look at.
Yes, thank you, Alex. This was my work. Healthy Communities Initiative Health Equity Grant, a grant that was funded and is still being funded by the Kansas Health Foundation. This grant took, well, it's a 3-year grant. We're now in the last year, but this grant was focusing on barriers to employment opportunities in Douglas County. And we initially went to focus in on and ask participants who were income impoverished, and we listened and went in focus group.
We lose you.
That created health department.
Yeah, you cut out just a little bit.
Sorry, I moved into a stronger Wi-Fi area, but it may not be. I'll cut it short. Maybe that's a sign. But no, this was taken over 100 voices and individual participants gave their responses and their answers to the questions of income barriers or barriers to employment opportunities. So this is just a graph that details that the top three reported employment barriers were prejudice, racism, lack of educational support and job match, and lack of transportation. And so with this graph,
You
Oh,
lose it.
you just
I'm
cut out
sorry.
one more time on us, but I heard the first couple things.
Oh, wow. Okay, so that's it for
You're cutting
obviously my daughters and my other kids are their Wi-Fi is taking up all my strength. But yes, I hope that you're understanding the graph. The graph was used and is a recent graph that was just taking collection of voices that were experiencing employment barriers.
Thank you, Christina. That's a Black mother in action. There you go. So thank you so much for sharing a little bit about this research that took place that helped inform our research process and also our research topics. I think that this is great that we have such great local data. Of course, you know, we have the local health equity report that came out in 2018.
What are
If you're
you guys
interested
doing?
in learning more local data as well. And then of course, we are updating the health equity report to include more things and just kind of, you know, it's been a few years now. And so we are updating that. And so definitely take a look for that. And so we want to say thank you so much for your time and your attention. I know that we went over a lot of material. We went over basically a whole literature review of Black patient-provider bias, pain management, dose gap. We went over our own research project with this Black maternal and child health grant. We went over our questions, our findings. We went over a lot. And so we would definitely understand if you had some questions or if you were thinking about our presentation and you had questions later. So I just wanted to put our email addresses up here on the screen so that you can see that as well. So I'll leave that up there for a second.
Great. And so thank you guys so much for, this is really interesting research. And I'm a nurse. I'm not a practicing nurse right now, but it's pretty fascinating to hear all of this and then look at it through that healthcare provider lens too. In your research, are there, I'm thinking of the coast just because that's typically where it starts, right? Are there facilities that are doing better than Douglas County is, especially like with medication administration and dosage and that kind of thing? And not just that, of course, but that's kind of dangerous. Something that I haven't ever heard of before, and it's very enlightening.
Yeah.
Do you mean the medication part?
The medication part of it, yeah, and metabolism and so forth. That it's fundamentally different according to race, and that it's not addressed at all.
Yeah, so there's not a whole lot of work being done around it because obviously it doesn't really benefit any particular pharmaceutical company or anything like that. But there is a lot of work around alcohol and East Asian communities and how, you know, even within college, like I like going to KU, I had to take a training that like I have to acknowledge that like, you know, people of East Asian descent may have a lower alcohol threshold and things like that. So there's a lot of work in terms of alcohol, particularly as, you know, because we are so consumed with DUIs and things like that as a community. And so there's a lot of work in that direction. But as far as medications and liver metabolism and race go, there's not a whole lot. And there's also research showing that, you know, you can increase the diversity of pharmacists and doctors and nurses and practitioners But that does not always result in better attention to race-based metabolism differences because the education isn't out there. And also something that I found was very interesting in the University of Virginia's work was that sometimes even the Black medical professionals and students held those same biases. And it's not that there's any kind of internal racism going on, but when you grow up in a world that sees you as less than and sees your pain as trivial, you can internalize those things and start to believe those things. When I read the University of Virginia's work, I actually, before reading that, I thought that my skin was thicker. I thought these things like these are just things I just grew up thinking.
Interesting.
But then reading that and learning that that wasn't true. So I believe that that's probably an experience that a lot of Black medical researchers experience. You know, they have some of these same thoughts, not all of these same thoughts, but some of them, the seed of them, and just really dismantling that and empowering ourselves to know that those things aren't true, that we aren't tougher than white people, that, you know, we don't have any reason to dismiss our pain and to think that it's not important in our medical treatments. That's also something that I noticed in the research. And so that's kind of a long-winded answer to your question, but basically there's not a whole lot. I haven't noticed anything, any particular place or lab that's like doing a good job per se, which is, but you know, not to say that there isn't one, I just haven't come across it.
Okay. Thank you.
Hopefully I'm
Hey,
coming in here. Oh, sorry. I'm so sorry, Tamara. I just wanted to talk about who's doing it better in making a shout out mental health. So Izazi Village is it's a great organization that is birthing doulas and other Black women who are helping to walk Black women. Yeah, Izazi Village in Kansas City. There we go. I said Topeka, didn't I? But yes, Izazi Village is doing a wonderful job. And they're doing it better. They're doing Black birthing and Black maternal health better and pre and postnatal better than we are. So hopefully we can connect with them and we can start learning how to have less birthing outcomes that are Black women, that all the quotes that we just shared or we just heard, we have less of that and less of those experiences.
Were either of you able to see the couple of questions that I offered you prior to today? And do you have any information on that you could give us now, or is that something I need to follow up with you on?
Yeah, I got a chance to look at that. So that's something that some of those things that you asked about in terms of what are the resources or educational resources in particular that are going to be made available. That's absolutely something that, oh, just see Aaron's comment. That's something that we are working on. We are developing infographics based on the research that we collected so that those can be shared in local clinics with Black patients and with medical professionals that probably need the information as well. And so some of those things are definitely being addressed. I have your email pulled up here because you asked about outreach program to talk about health resources and statistics. That's something that's on our list. And
you know, I'm thinking in terms of the preparation that should go into expectant mothers and their infants and preparing them for preschool and further education. You know, if they don't receive the proper nutrient supplements, whatever.
Yeah.
And I don't think people think about supplements, but if their brains are not developing properly, they're not going to be ready for school. So those are the things that I wonder if anybody's thinking about.
Yeah, that's something that, so my background in neuroscience, we look a lot at, glycemic loads, so like sugar loads and how that plays a role in Black infants, especially because Black mothers are more likely to have diabetes, gestational diabetes, and things like that, and how that can affect neurodevelopment in fetuses as well as infants, how that like plays out in the first year of life, because having, sugar highs and lows can affect the hippocampus and areas that are central to learning and memory formation. And so that can obviously play a role in learning outcomes as well for Black children. But there isn't like a whole lot of that I know of at the health department, other than we have a healthy families sector that works on healthy foods and healthy eating. And then of course a WIC and other things that's available there. Yep, Christina's agreeing. But yeah, I thought that your question was really good because that is something that people don't, it's like a deeper health thing that people don't worry about. It seems like we kind of just worry about keeping people alive, and then these other things kind of start to become important.
Usually nutrition, and we think that, you know, if people eat properly, they'll get what they need, but that's not always the case, especially when they've had a long-term family history of poor health
Yep.
care. And another question, were you able to determine if what percentage of these young women had supportive partners?
I'm gonna definitely let Christina answer some questions too.
Hopefully my audio is connecting. Yes, we asked questions, and we were specifically asking questions about their birthing experience. Now, when they expressed a lack of societal support or community support, we noted that. Not all of the women were with partners, but we didn't ask those questions about their domestic situation. It was more focused on wanting to know their experiences, so as a healthcare organization or healthcare providers can do better. When we understand that your economic status does not prohibit bad and negative birthing experiences, you know that, I mean, with the best partners and the best support and care that you have at home, there's also the opportunity for you to not experience the best care when you are within the medical facilities. So that's what we wanted to understand. We wanted to make sure that there was some accountability to the ways in which women and Black women walk through the medical offices and how they're treated. I hope that answers your question.
Yes.
Yeah. Tamara, real quick, this is Amber Sellers. I wanted to ask our participants a question before I had to jump off real quick. When you look at, while the League is known for being a group that focuses on voter advocacy and voter rights, healthcare reform is one of our top priorities outside of voting rights and voting advocacy that the group focuses on. And again, both you, Christina, and Alex have brought to the group work that has kind of been under the current here in the state of Kansas for a very long time, and it's just now getting somewhat of its just due as far as the lack of advocacy that has gone on many different levels in our state in regards to Black maternal health and also Black infant health. And so thinking about that as far as advocacy, policies, things of that nature, being the group that we are and the advocacy group that we are, what would you like to see a group as such do on behalf of Black mothers when it comes to advocating for policy and healthcare reform? What is something that you believe this group can do here in the state of Kansas to advocate for Black mothers?
One of the first things that I'm thinking about is, and it's something that I think a lot of us are very familiar with right now because an election just occurred or it's still occurring, is people's belief that politics are not related to healthcare and that their vote won't make a difference outside of just local elections. I think that your group's work in increasing the voter base and informing the voter base is very instrumental in making those health changes happen. And I think advocating for things like that affect Black families, maybe not so directly to maternal health, but things like living wage, things like universal pre-K, things like that will greatly help Black families and in turn Black children. Are things that obviously have voting components to them. And there's also other local groups like the Anti-Poverty Coalition, Human Services Coalition, and so forth that are working on some of these policy things that could obviously use support from a group whose expertise is within voting, to be able to work towards these ends. And so that's like the very first thing that comes to my mind, but I definitely want to leave Christina a chance to have any of her suggestions as well.
Yeah, thank you. And
Oh, you're cutting out. I really want to hear it too.
uh-oh.
Oh, I hear you right now.
Okay, right. So with our anti-poverty work, I'll just mention that because we are working on creating policies that address the the Black children in Douglas County and how we can help support our BIPOC community, and that's our goal. And so we're looking at policies that address those goals and looking at how those policies could inadvertently cause more of a disparity. So, just yesterday we had a meeting talking and addressing on how we can create a living wage, a sustainable wage for a BIPOC community. And that is a policy that we can look at. And I don't know how that gets done, but my suggestion would be to maybe come into the work that we're doing with our anti-poverty work group that's part of the community health plan plank and help us create these policies and then move them into something in our community that looks to address income disparities, lack of access to food and food security. And just, I feel like, as a Black parent, Black mother, education opportunities for my children are something I have to advocate for. So moving and pushing the needle to voting for things that are going to make sure that Black health care and Black experiences and Black people are getting more money, more support, and just an overall sense of understanding that this community does care and does support our BIPOCs. That's really a political way to say, I don't know, but let's work together and make something happen.
And that's really what we want to do, to work together to make something happen, because something needs to change.
I have a question about, and I didn't get on initially, so you may have addressed this. Does your research from health, from births here in Lawrence, do you have a baseline? Is there research about low birth weight? How many low birth weights and race?
Yeah, we do. LMH Health and the health department and some other area partners, there is research about the low birth weight rates that we have here, as well as other health disparities that are race-based. Oh, looks like Amber just took off. Let Amber know that we thank them for that question. I meant to say thank you.
I did. Yeah, that was a really great question, because that's one of the things that we would like to do more of, is focus on building the community partnerships to really make a big difference, besides just the voting part of what we do, which is essential, because it all kind of starts there. And if you have an civically engaged community, then chances are their health outcomes will be better. But you have to do a lot of education to do that. But we would love to work more with you, as you, like you were talking about, Christina. I don't know if that means one or two of us coming to the meetings that you were talking about. It was a city commission, county, what was it again?
So this is a group, it's an anti-poverty work group. We are looking at policies. We meet weekly, and I say we because this is a commutative, this is a multi-sector support team, but we definitely want input from the community, because this is what we're trying to do is support the community. So I can definitely send you some information, and that's a part of the community health plank of the plan.
Faded away right there at the end.
Yeah. Oops.
Did it lose?
I may just keep to the chats for now.
So sorry that
Yes.
you're having that issue, Christina.
Sorry. Yes, sorry you're having that problem, but please share the information. That would be really great.
Yeah, and I put my email into the chat box in case it's easier for someone to copy and paste it than having read it or typed it from the presentation. Definitely reach out. We have a couple of different, Christina mentioned the new community health plank of racism as a public health crisis is the title of it. And so we are allocating resources towards things like race-based health disparities and other things happening in our community. And then of course, there's the ongoing Anti-Poverty Coalition's work. There's, I think on the United Way's website, let me just drop it in the chat. I think I can find it really quick. There we go. So I'm dropping that in the chat really quick so you can read a little bit more about that group's mission and work. It's been around for a few years, and currently we are working on specific issues like fees and fine justice in the law enforcement system. We're looking at childcare options, especially as pertains to COVID and kind of the unique challenges parents are facing. Decriminalization of poverty, so looking at things like the box on job applications, living wage and things like that. I'm just kind of like listing a few of the things, but yeah.
Yeah, that would be great. Thanks. We'll take a look at that. Did you all have more questions for Alex and Christina? There's just so much, and like you said, you touched on so many different things that could really be a deep dive into so much information and directions to take.
So I did ask if Alex and Christina would be willing to come back at a later date and talk about either the continuing results of their research or sort of a side topic. We would be very happy to have them. I'd also like to extend an invitation for them to join League of Women Voters, if I might be so bold.
That would be really, really great too.
It would, because we need your voices, your young, brilliant voices. And so whether you join or not, just consider us a home to be able to support you in getting your information out there to the public.
Definitely. Yeah. This
Well,
was
thank
really a
you.
great presentation.
Yeah, no, thanks for listening to us and giving us an hour of your time. We really appreciate the attention to these topics and to the things that we're working on. We certainly are, we're doing this 24/7. And so it's really nice to get to step back and kind of invite people into that and kind of share that, the things that we're finding out with people. It's really nice.
Have you all done any partnership like with the library? And I'm just thinking to get it even to a broader audience as much as we can.
Yeah, so we're developing a report. Thanks for asking. We actually forgot to talk about this. We are developing a report. We're just waiting for it to get approved at this point. We have a couple of little things here and there to kind of tweak and make perfect. But there's infographics, there's a full report that fully lays out the entire literature review, the entire research process, all of our methods, how people could duplicate this work elsewhere, and how we adjusted to COVID and how that was a learning opportunity that we could also be sharing with people. We have so much information. I think it's over 30 pages of a report about our research. And so that's something that the health department is going to approve. And then of course we want that to be distributed so that local medical spaces can learn from it, maybe spaces up at KU, Haskell Indian Nations, as well as Black women locally. So we're going to have the full report, but we're also trying to generate something that is at like 6th grade reading level that everybody can get on board with and digest. That's maybe just 1 page long. So we have a couple of different materials that we're developing because we definitely want this work to make a difference, and we don't want it just to sit on the shelf.
Great.
That's the truth. Yeah. To get the information out there and then make a difference, make some changes.
Yes.
Yeah. And we would definitely look forward to you all coming back and talking to us some more. Maybe you guys can figure out a date. Tamara, Denise, Alex, and Christina.
All right, you heard it from the president.
Yeah, there's lots of topics. I actually have a presentation that's just about early suffrage and how the interactions between Native American peoples influenced that. I was recently hosted a panel with a filmmaker that created a documentary about it that some of you may have been at. Yes.
That's great.
Okay. I knew I recognize some people. And so that would be that's something that I've been developing material about because it's really fascinating. And then of course, Christina can present about a whole host of things, local, relevant. She's been engaged in amazing community liaison work and findings in her own research that she was doing even before I joined on and was doing anything. So I know Christina's got other things to talk about as well. And we would of course love to give an update on our research, especially as the report comes out in terms of things else that we find.
Yeah, that would be great. And one of the I think serendipitous things about that it has resulted from COVID is that we can do these Zoom presentations and people have a lot easier access, I think, to attending, and we're able to do more of them as a result. So we don't have to limit ourselves to just once a month. But we can do a series or whatever. So yeah, that would be great. All right, does anybody have, yes, Denise.
Can I mention, we won't have a hot topic in December, taking the month off. Whew, it's been a year. But join us again in January for another hot topic or two. And this recording will be on our YouTube channel, which Tracy Matthews has just recently gotten up and running, which I don't have the link to right now, but we have one now.
Oh, yes.
We could probably get her to send it to Alex and Christina along with the rest of us, maybe, right?
Yep.
Yes.
Okay.
Yeah.
Okay.
So thanks again, though, Alex and Christina. That was really, really a great presentation.
Yeah.
Thank you, ladies.
Thank you.
Thanks.
Thank you.
Okay.
Thank you.
Bye-bye.